As the additional director of Trivandrum Institute of Palliative Sciences, which is a WHO collaborating center for training and policy on access to pain relief. He has a diploma in palliative medicine taken from India and Cardiff, and also a master's in palliative medicine from Cardiff. He comes with a 20 years of vast experience in palliative care. He's also a honorary tutor at the School of Medicine, Cardiff University, UK, and a national faculty in palliative medicine. He's also a mentor for the Quality Improvement Project under Equip India. He has published more than 10 articles in peer-reviewed journals and has written chapters on palliative medicine in a few textbooks. The clinical services, academics, and research wing of Pallium India are overseen by Dr. Sunil Kumar. So, sir, I warmly welcome you to this session and hand over it to you. Thank you, sir.
Thank you, Sripriya. Am I audible?
Yes, sir. Yes, sir.
Okay. So, good afternoon, everybody. And today we are planning to cover opioids. And let me share my presentation. So, what we are planning to cover in this topic is the common opioids available in India, which are used for chronic pain management, and what are the mechanisms of opioids. And another important thing would be the practical aspects in the opioid use, because you might have heard about many things, or there are some practical things which are different from the theory written pharmacology textbooks. Then adverse effects of opioids. It is very important to know, because otherwise we will have our own fears and the knowledge what we get from the textbooks would not be the real side effects or adverse effects of opioids. Then it is also important to understand what are the different prices of opioids, because there are many opioids which are available at low cost and to very high cost, that is like buprenorphine or fentanyl. And one of the main reasons for inadequate symptom control is the patient would not be taking the medication you prescribe, because they do not have the money to buy that if you prescribe the high cost medication. So with this introduction, I'm going to the WHO analgesic ladder, which all of you are very familiar with. So in the first step, we have non-opioid plus or minus adjuvant analgesics. And in the second step, we have opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjuvant. And in the third step, we have opioids for moderate to severe pain, plus or minus non-opioid, plus or minus adjuvant. So we know that from the second step onwards, we have opioids. And can anybody tell me what are the opioids available in India for treating chronic pain? You can unmute and speak.
Morphine, sir.
Yes, morphine. Very good.
And fentanyl.
Yes. Anything else?
Fentanyl patches also, sir.
Yeah.
Buprenorphine.
Buprenorphine. Yes. Anything else?
Tramadol also, sir.
Yes. Tramadol. Okay. So we have opioids from the second step. The second step is used to treat moderate pain. So in the second step, we have opioids for mild to moderate pain. So what are those opioids? Opioids for treating mild to moderate pain. So this includes tramadol, which many of you would be using. Then we have tapentadol, which is a newer derivative of tramadol. Then we have dextromethorphan and codeine. So these are the opioids used to treat mild to moderate pain. And what are the opioids for treating moderate to severe pain? So we have morphine, fentanyl, and methadone. So there are many other opioids available in India, but the role of those opioids in chronic pain management is very limited. So that's why I am not talking about other medication, even though somebody has mentioned about the buprenorphine, but that is not the standard worldwide. So morphine is the gold standard for pain relief worldwide. And you can see a patient here. So what does he communicate to you? If you see a patient like this, what would you understand? Anybody?
He is in pain.
Yeah, he's in pain. He's in severe pain. Okay. So if you see such a patient, how do you manage?
First, we will assess the pain,
Yes.
the severity of the pain, followed
Yes.
by task
Yeah.
radiation, and we'll assess the patient completely.
Yes.
And according to the pain scale, then we'll decide if it is mild pain, then we'll start with step 1, or
Okay.
moderate to severe, then we'll go to according to the WHO step ladder.
Yeah. So this patient has a pain score of 10 by 10. So which step would you select from the WHO analysis ladder?
We'll start with strong opioid along with the adjuvants and along with paracetamol or NSAID, whatever.
Okay. Thank you, Dr. Shruti. So you can see this patient, he is a 56-year-old man with carcinoma of the larynx. And his main problem is severe pain around neck. And it is always 10 by 10. And there is no radiation of pain. And this pain was there this much severe for the last 2 weeks. And you can see he is also unable to sleep because of the severe pain. So what opioid would you use? Which opioid?
Morphine.
We will like to start with or tramadol.
Okay. So we have two answers. One is tramadol and the other one is morphine. So which one should we select? And you can justify your answer. Dr. Shetri, why did you say morphine?
This is severe pain, worst imaginable pain, 10 on 10. And so I would like to prescribe strong opioid, and I'll titrate the drug. First, I'll start with morphine and titrate the drug, and then I'll decide the dose of the morphine, how much to give.
Yeah, thank you. Dr. Shahada, why did you say it's
Yeah,
tramadol?
it is de novo because he has not been opioids earlier. I would like to start with tramadol and see. If he is
Yes.
responding well, then we can keep morphine still as a reserve.
Okay.
And
So what we
about
need to
availability.
yes, thank you. So what we need to understand is you can select the step from the WHO analysis data corresponding to the pain. So this patient has a pain score of 10 by 10. That means he has a very severe pain. So the step of WHO analysis ladder used to treat severe pain is step 3. So we need not start with step 1 and then go to step 2 and then go to step 3. It is not needed. We can directly go to step 3 if the patient has severe pain. So here the patient has severe pain, so you will start with morphine, as we told. Okay. So you can see this patient after an hour is smiling at us. So what is the magic behind this? So it is by intravenous morphine titration, or some people call it as intravenous morphine trial. So what is intravenous morphine trial? So you will give injection morphine 1.5 milligram at 10 minutes interval. Okay. So what is the immediate side effect you are expecting by administering injection morphine 1.5?
Either respiratory depression, sir, or nausea, vomiting.
Okay. Anybody else? Any more comments?
Sedation.
Sorry?
Sedation. Patient will go to
Yeah, that is correct. Thank you. Yeah. So the immediate side effect by administering 1.5 milligram of morphine is nausea and vomiting. Okay. So before administering morphine, you have to give an antiemetic, and we usually give injection metoclopramide 10 milligram IV. So injection metoclopramide 10 milligram IV is given first, followed by injection morphine 1.5 milligram at 10 minutes interval. Okay. So how long would you continue to give injection morphine? Or we can say what is the end point of morphine titration?
pain relief or sedation, whichever comes early.
Yeah, it is satisfactory pain relief. Okay. Either satisfactory pain relief or sleepiness, whichever be the first. So what you have to understand is all the patients may not have good pain relief or satisfactory pain relief with morphine. And in those patients, and the pain may not be opioid responsive. And in such cases, you will have the patient will develop drowsiness earlier than the satisfactory pain relief. So that's an indication to stop the morphine titration there. Okay. So for doing an intravenous morphine titration, you can have a chart like this, which includes time, pulse rate, respiratory rate, blood pressure, pain score, is the patient drowsy or not, what is the dose of injection morphine you have given. So in this patient, you can see at 10 o'clock, the nurse recorded the vitals. Patient says my pain score is 10 by 10. You are looking the patient, he is not drowsy. So you will give injection morphine 1.5. Wait for 10 minutes and again record all the vitals. Then ask the patient, what is your uh, pain score now? So you can see here, by 10:30, the patient has received 3 doses and his pain score has come down to 1. So that means patient has satisfactory pain relief. So this is an indication to stop morphine trial. So this patient has received total 4.5 milligram. So can we do this injection morphine trial as an outpatient procedure? Or should we admit the patient?
We can do as an outpatient procedure, sir.
Yeah, you can easily do it on outpatient basis. So this patient has received 4.5 milligram of IV morphine and the patient wants to go home. How would you convert this dose into oral dose? How much morphine should we give orally when the patient is going home?
3 times the IV dose is what suggested.
Okay. Yeah.
Or 15.
Yeah. So in a way that's correct, but here an approximate 1:1 ratio. That is initial. What is the dose of initial intravenous morphine that has produced good pain relief? That can be given as the first oral dose. So this patient received 4.5 milligram of morphine IV, and so the oral dose can be 4.5 milligram, but 4.5 milligram tablet, it's not practical to give 4.5 milligram. So the next possible dose would be 5 milligram. So we have 10 milligram tablets, so you can make it half and give 5 milligram. So this is a study conducted by Dr. M.R. Rajagopal and his colleagues in 2000. That gave intravenous morphine for treating cancer pain. And they found that 1:3 ratio, it is not applicable here because opioids will take about 24 hours to have a sustained blood level. But here, then if you convert the patient from IV to oral, then 1:3 ratio would be good. But here, this patient has not received injectable morphine for 24 hours. It is just over a few minutes. And then you are converting it into oral. So the um, uh, 3 times conversion would be very high. So it is not advisable to convert into 3 times. The 1:1 ratio it can be the good starting point when you do an intravenous morphine trial and then converting the patient to oral morphine. Okay, so if you give morphine, it should be like this. For this patient, we are giving 5 milligram, so 10 milligram tablet, half every 4 hours. So you can say that nurses usually administer, they have a medication schedule when to administer. So usually at 6 a.m., then followed by 10 a.m., 2 p.m., 6 p.m., and at night 10 p.m. So many patients who are in pain will be sleeping in the morning hours. So you need not wake them up at 6 a.m. To administer morphine, but wait for them to wake up maybe at 7 o'clock or 8 o'clock. And he administer first dose when he wakes up. But next dose should be at 10 a.m. Then till 6 p.m. we will continue to give the we will follow the time schedule, but we will not take till 10 p.m. To give the next dose. We can administer the last dose, then the patient goes to bed. Here, what you have to understand is we are administering the double dose of morphine. You can see in other times, in the morning time, we are giving only 5 milligram, but at bedtime, they are giving double dose, that is 10 milligram. So this is how it is administered. And otherwise, you have to administer a dose of morphine at 2 a.m. So it is very difficult for a patient to wake up at 2 a.m. to administer morphine, and then falling asleep would be a problem. In addition to the regular dose, you can also give SOS dose. SOS dose would be the same as the regular dose. Okay. So if you do not have injectable morphine, and injectable morphine, the strength would be variable from state to state. We get 15 milligram morphine in 1 ml. So what we do is we will dilute 1 ml of morphine with a 9 ml of normal saline. So that will become total 10 ml. So total 10 ml contains 15 milligram. And from this, each 1 ml would be 1.5 milligram. So that's how we administer 1.5 milligram every 10 minutes. But if you do not have injected morphine, then oral morphine can be given. And if a patient is opioid naive, that is a patient who has not taken any opioids previously, then you should start with morphine, oral morphine, 5 milligram for hourly and SOS. If the patient is already on weak opioids like tramadol, codeine, tapentadol, then you can straight away start with 10 milligram for hourly and SOS. So our patient, Mr. X, we started him on 5 milligram of morphine for hourly and SOS doses. And he said he had very good pain relief for the last 2 weeks. But then he needed SOS dose for the last 4 days, and he is taking 3 SOS doses. What shall we do now? And another question is, how frequently would you give SOS dose of oral morphine? Anybody have any comments?
We need to increase the dose of morphine, sir.
Okay.
Instead of 5 mg, titrate with the 10 mg.
Okay. Yeah. And how frequently would you give SOS dose of oral morphine?
4 hourly.
4.
4 hourly SOS dose. So we are giving morphine, oral morphine regularly at 4 hours. I am asking, in addition to regular morphine, how many SOS dose of oral morphine can be given? Or what should be the minimum time interval between 2 doses of oral morphine?
4 hours is the minimum time, sir.
Okay.
For
So
SOS dose, minimum interval should be 30 minutes. So that is the time required for action. So minimum 30 minutes should wait for after regular dose to take SOS. And we should count the number of SOS doses that are being taken. If it is more than 2 SOS doses for 2 to 3 days, then we should think of increasing the dose.
yeah, thank you, Dr. Suraj. So what he told is right. So our patient is already taking 3 SOS doses. That means the dose that we are giving is not sufficient. So if the patient is taking 2 or more than 2 SOS doses, PRN is same as SOS. Okay. So if the patient is taking 2 or more than 2 SOS doses, then increase the dose of morphine by 30 to 50%. And this can be done every 24 hours. So the dose of morphine can be increased every 24 hours if the patient doesn't have pain relief. So for our patient, he is already taking 5 milligram of morphine. And if you increase it to 50%, that means 50% of 5 milligram would be 2.5. So 5 plus 2.5, it would be 7.5 milligram.
7.5.
Yeah. Or some people would find it very difficult to break the tablets into 4 pieces. So even 10 milligram would be okay in this patient. So from 5 milligram, we have now increased to 7.5 to 10 milligram Q4X. And how frequently would you give SOS dose of oral morphine? Dr. Suraj told it's 30 minutes. So we need to understand a little bit of pharmacology here. So this is the poppy plant. It is known as Papaver somniferum. And you can see the poppy field. And poppy is actually legally grown only in 3 states of India. Anybody knows those 3 states? It is UP, MP, and Rajasthan. Okay. And I see Dr. Saheda, behind you there is a flower which looks like the poppy flower. Where are you from?
I'm from Andhra Pradesh, sir.
Okay. It is not a poppy, isn't it?
No, sir.
Okay. Okay, UP, MP, and Rajasthan. These are the only 3 states where poppy can be grown legally. And the seed-like thing, which is known as pod, POD pod. And you can see the farmers are making small cuts in the pod, and you can see the sap is coming out. So they will collect this sap and dry it in sunlight, and then this will be transported to government opium and alkaloid factories. From where they will make morphine powder out of it. And then this will be transported to various pharmaceuticals, and they will make morphine tablet, injection, etc. Okay. So morphine is actually hydrophilic. That is, it is water soluble. Because of this water solubility, morphine takes little long to work, and it has a longer duration of action. And another thing is that morphine is actually bitter. So if you powder the tablet, then probably you have to sweeten it with fruit juice or sugar. Otherwise, it will be very bitter. So please remember this. And many people administer morphine through many routes, but sublingual, buccal, and gingival routes. These are not good routes for morphine administration. And if somebody says after sublingual administration, I have good pain relief, then you have to think that the person has swallowed the tablet. That's why he has good pain relief. So morphine is not advisable to be administered through sublingual, buccal, or gingival routes. So morphine undergoes first pass hepatic metabolism. So what happens here? So once you swallow the morphine, it will be absorbed from the upper small intestine, and it will go into the blood vessels of upper small intestine. From there, it will go into portal vein to liver, where metabolism takes place, and the metabolites are liberated into the systemic circulation. Okay. So morphine is extensively metabolized. Only 10% of morphine bypasses liver and reaches systemic circulation. Otherwise, 90% of morphine is converted into metabolites. And there are two major metabolites. Morphine 3-glucuronate, which is in short is known as M3G, and the other one is M6G or morphine 6-glucuronate. And you can see that M6G is formed only in small quantity, that is 5 to 10%. But this is the active component, or this is the metabolite that will give you pain relief. Okay. So now you understand that it will take some time to start the action when you administer morphine orally. So as Dr. Suraj told, the pain relief will start by 30 minutes, but the peak will be by 1 hour. Okay. So it is advisable to wait till 1 hour for pain relief. So once you give morphine, then you have to wait for another hour to administer the next dose. Okay. So how frequently would you give a first dose of oral morphine? You can give every hour. That's the answer. So our patient, we stabilize his pain with 10 milligram of morphine every 4 hourly. But patient says it is very difficult to take it every 4 hourly. And you might have seen many patients who is not very regular, or the compliance would be very poor, not only with morphine, but also with other medication. And you can also think about yourself. Suppose if amoxicillin clavulanic acid is given to you and asked to take it 3 times daily for 5 days, how many of us are going to complete the antibiotic course? So this patient also says it is very difficult. Is there any other option? If you give it less frequently, I am willing to take it. Do we have any option?
Yes, sir. We have sustained
sir.
release forms.
Okay. Sustained release morphine. Okay. So sustained release morphine, Dr. Sayada, you can talk a little bit about sustained release morphine.
Yes, sir. Like 30 mg sustained release we have, which will have a prolonged effect, especially when we administer in the night time.
Okay. So what is the duration of action of sustained release morphine?
Comes to almost 6 to 8 hours.
10 to 12 hours.
Yeah, it's 12 hours. 12 hours. So the usual morphine tablet, or which we call it as immediate release morphine tablet or fast acting morphine tablet. Both are same, or regular morphine tablet, which the duration of action is 4 hours. That's why we need to administer every 4 hours. But here, sustained release morphine has a duration of action of for 12 hours. So this patient is taking 10 milligram every 4 hours. That means he is taking 60 milligram per day. So what would be the dose of sustained release morphine that you are going to administer to this patient?
30 mg SR DD.
Yeah, 30 mg SR
Or
DD.
twice a day.
Yeah. But this patient can also have pain in between. So what would you do for that pain?
The regular dose,
Yeah.
7.5 mg.
Or one,
Yeah.
1/5 to 1/3,
Yeah.
10 mg tablet.
Yeah, you're right. So here the patient is taking total 60 milligram. So if you take 1/6, that is 1/6, 60 by divided by 6, that is 10 milligram. So 10 milligram immediate release tablet would be the breakthrough dose. Okay. So you have to advise the patient to take immediate release tablet 10 milligram if they have pain in between. So what are the preparations of morphine available? So syrups are available, tablets as well as capsules, both immediate release and controlled release are available. Then injection, it is 15 milligram for us, but I understand that it would be different for many of you. In many states, it would be 10 milligram in 1 hour. So again, our patient is already on 10 milligram of morphine every 4 hourly for the last 6 months, and then he was brought to casualty with excessive drowsiness, and you ordered many investigations to find out the cause, and you found that the total count is 13,000, blood urea is 20 milligrams per deciliter, and serum creatinine is 5 milligrams per deciliter. Would you do anything with the morphine dosage?
We have
Decrease
to
the
reduce
frequency.
the
Sorry?
Decrease the frequency of dosing to 6 hours.
Okay. So can you explain why would you like to decrease the frequency?
The metabolite, 3-glucuronide metabolite is excreted through kidney, which has longer half-life than morphine. So that action is because of the metabolite.
Okay. So Dr. Siddharth, I think you meant M6G, not M3G. M3G doesn't have much action in our body, or it may contribute to neurotoxicities. But M6G is a component which will give you the pain relief. So here, what is the cause of drowsiness in this patient? Why patient
side
is
effect
drowsy?
of morphine.
Okay, side effect of morphine. Yes. Any other reasons?
Metabolic encephalopathy.
Okay. Anything else? So for this, there is you can see patient has an infection, total count is elevated, but are there any other cause? So what you have to understand here is the excretion of morphine, how morphine is excreted from the body. So morphine is excreted by glomerular filters. So you can see this patient's creatinine is 5 milligrams per deciliter. That means patient has deteriorated kidney function, and the patient may not be excreting the morphine from the body. So whatever you are administering, it would be there in the body. And as Dr. Suraj told, the M6G, which gets accumulated in renal failure, and its half-life would be prolonged in such situation. And this will also lead to many problems, including drowsiness, myoclonus, and many other symptoms. So what should we do here? Don't give morphine every 4 hourly in such situation. You have to increase the spacing, maybe make it TID or 8 hourly, or in some patients even once daily. Or you can use alternate opioids. Like there are some opioids which are renally safe. Anybody knows which are the renally safe opioids? If the patient has CKD, which opioids can be administered? So methadone, buprenorphine, and fentanyl are comparatively safer in chronic kidney disease. So it is not only increase the spacing, but also you have to reduce the dose of morphine. Okay. So what are the routes through which you can add? Okay. So this is the patient with chronic kidney disease or renal failure. We reduce the dose of morphine to 5 milligram 8 hourly, and he was comfortable, but then he was unable to swallow morphine. Probably the patient is terminal, and that's why he is unable to swallow, and he is at home. So what can we do now for pain relief? If he do not take the morphine, then he has severe pain.
We need to go for alternate opioids.
Okay,
Like
alternate opioids.
fentanyl.
We can give correctly.
Correctly. Okay. So what would be the dose of parenteral morphine?
We double the dose when we give rectal administration, sir.
Okay. What are the alternate opioids that you were talking about?
Fentanyl patches.
Fentanyl patch. Okay. So can anybody tell me what are the routes through which you can administer morphine?
Subcutaneous.
Okay. Most common route is oral, then intravenous or
Intravenous.
subcutaneous, then
Rectal.
rectal, epidural, intrathecal.
Intrathecal.
All these are the routes through which we can administer morphine. So in this patient is at home, and he's terminal. So probably we need to ask the caregiver to administer morphine correctly. Okay. So you can use the same immediate release morphine. Add 2 drops of water, make it a paste, and do the rectal examination, and just deposit this paste on the rectal mucosa. And the dose and the duration of action is same as oral route. So whatever you are giving orally, that can be administered correctly. The effect would be same. And even there are some literature which says rectal route is more superior than oral route. Okay. So we would give 5 milligram correctly 8 hourly for this case. So now we are moving on to another patient. So this is a 55-year-old lady with carcinoma of the colon who complains of abdominal pain, which is continuous in nature, and she is on 10 milligram of morphine 4 hourly, and she has good pain relief. So After starting morphine 10 milligram every 4 hourly, she has good pain relief. And here also, the patient don't want to take it every 4 hourly, and she complains to the doctor, and then doctor asks the lady to replace the morphine with a 25 microgram fentanyl patch. But next day, the patient comes to your clinic and tells you that, doctor, I replaced the patch after 5 hours because it was not giving me any pain relief. So what would you do for this patient for pain relief now?
Usually, fentanyl patches take some time for the onset of action, sir.
Okay.
So,
So
meanwhile, we can allow one oral dose till the effect takes on.
okay. So there are some important things we need to know about fentanyl patch. What Dr. Sahada told us, right? So you can see this is the fentanyl patch, and there is an adhesive layer which you have to peel off during the application, and there is a membrane, the release membrane, which would regulate the fentanyl entry into the subcutaneous tissue. You can see that there is a lot of capillaries in the subcutaneous tissue, and the fentanyl will be liberated into the subcutaneous tissue. Then it forms a subcutaneous tissue storage. Okay, and from this subcutaneous tissue storage, fentanyl will be liberated into the system surface. So for this subcutaneous tissue depot to develop, it will take about 8 to 12 hours. So this is most important. Once you apply the fentanyl patch first time for a patient, it will take about 8 to 12 hours to start the action. Okay. So this patient replace the fentanyl patch after 5 hours. So these are the this is a real story because we see many patients, and this is one of the patients who came to us who told this history. So it's our duty to explain what should be done if a fentanyl patch is applied. So you have to educate the patient that it will take about 8 to 12 hours for pain relief. So till that time, the patient should take the previous opioid that he was taking. So in this case, the patient was taking tablet morphine 10 milligrams. So you should ask them to take maybe at least 2 doses of morphine. Okay. And the duration of action of fentanyl patch is 72 hours. And this is another thing. When you apply the fentanyl patch, you should not shave the area. Okay. If you shave the area, there will be micro abrasions, which can actually increase the absorption of fentanyl. And fever is also going to affect the absorption. So you should tell the patient not to go near the stove, or do not take hot bath, etc. So transdermal fentanyl patch, because now you know that 25 microgram fentanyl patch means 25 microgram would be liberated every hour. We cannot alter that concentration. So if the patient has pain in between, we will not be able to alter the concentration. You have to actually administer morphine. So it is not advisable to start transdermal fentanyl patch for a patient who has unstable pain. Unstable pain means sometimes the patient has very severe pain, and after some time it comes down, then it again goes up. So this is the type of patient for whom we should not apply fentanyl patch. We should actually start with short-acting opioids like morphine, and then find out a dose at which the patient is having stable pain, and then you should convert if needed you can convert morphine to fentanyl patch. But I know now there is a practice of even applying fentanyl patch in patients for post-operative pain relief, where we actually do not know what would be the amount of opioid requires. And fentanyl is available in 3 forms. Injection is available, then transdermal fentanyl patch, and there is another preparation called oral transmucosal fentanyl citrate or OTFC. So which is like a lollipop. So you have to rub it over the buccal mucosa, and that will give you immediate pain relief. So this is especially useful for a patient who has incident pain, that is movement related pain. So if the patient has movement related pain, that pain will be short lasting. So you have to use a short acting opioid, which will be acting at the moment. So fentanyl lollipop or OTFC would be an option in such situation, but it is not available as of now in India. And fentanyl is more potent than morphine. It is about 100 times more potent than morphine. And if you want to convert oral morphine to fentanyl, you need to remember this conversion. 60 milligram of oral morphine equivalent per day is equal to 25 microgram per hour patch. So that means 120 milligram of oral morphine. If a patient is taking 120 milligram of oral morphine, it would be equal to 50 microgram patch of fentanyl. Okay. So this is another patient, Mr. P, 70-year-old man who has carcinoma of the lung and is complaining of throbbing pain on right front of chest. It is continuous in nature and pain score is 5/10. He is a non-epileptic and is on levetiracetam 500 milligram daily. How do you manage this pain? Anybody? Anybody? Tramadol. I can see Dr. Manisha says tramadol. Yeah. Any other answers?
Nitroglycerin, but it's not just.
Nitroglycerin?
No, sir. Morphine.
Yeah. What is the pain score here?
Hmm.
Vijay,
I
Dr.
did.
Vijay says methadone. What is the pain score? It is 5/10. So which step of WHO and aggressive ladder should be?
Mild to moderate. Step 2.
Mild to moderate.
Step 2. Yeah. So in the step 2, it is opioids for mild to moderate pain, plus or minus non-adjuvant. Plus or minus non-opioid, plus or minus adjuvant. So which opioid would you select? Yeah, I can see.
Tramadol or codeine.
Yeah. Okay. Tramadol or codeine. But nowadays nobody uses codeine because it has many problems. One is it is dependent on cytochrome P2D6 for metabolism, and it has genetic variation among Indians. So many may not have or metabolize codeine properly, and so there would not be pain relief for many patients also. That's another thing. It produces constipation more, and it need to be given every 4 hourly. So these are something, and it is costly. So tramadol is the opioid which is used by many of the doctors. So here, any problem in giving tramadol for this patient?
tramadol can sometimes cause convulsions,
Yes,
very rarely.
yeah,
So this patient is a epileptic, so we have to give it cautiously.
yes. Okay. So tramadol, its potency is less compared to morphine. It is 1 by 10 as potent as morphine. So 100 milligram of tramadol is equal to 10 milligram of morphine. And it has a dual mechanism of action. That is, it acts like an opioid. So it acts on opioid receptors to produce action. In addition to that, it also acts like tricyclic antidepressant. So it inhibits the reuptake of noradrenaline and serotonin. So that's the other mechanism of action. Okay. And maximum dose recommended for tramadol is 400 milligram per day. And as Dr. Madhavi told, it has a tendency to reduce the seizure threshold. So in a patient who is a non-epileptic, tramadol can sometimes produce seizures. It is very, very rare. I have not seen any patient with seizure due to tramadol, but theoretically, yes. And if you give injectable tramadol to any patient, give it very slowly. Okay. So now we have another patient, Mrs. T, who is on tab morphine, 50 milligram tube per hour. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How do you manage this patient? Patient is in severe pain. Which one would you select? Which one would you give to this patient? Injection pentazocine, oral morphine?
Yeah, is it any breakthrough pain or what we have to rule out, sir? For immediate relief, we go for injection forms.
Okay. So that means you would give injection pentazocine.
Yes, sir. But
Okay.
pentazocine also has seizures.
Okay. Any other comments? Okay. So let's look at pharmacology again. So what do you mean by an opioid? There are two properties for a drug to become opioid. One is that its action should be produced by combining with opioid receptors. And the other one is its action should be antagonized by naloxone. Okay. And according to the action, the receptors of opioids are mu, kappa, and delta. So these are the three opioid receptors. And depending on the action on opioid receptors, the opioids are classified into three: agonist opioids, antagonist opioids, and agonist antagonist. Agonist means it's an opioid when combined with opioid receptors will produce physiological action. Physiological action means pain, constipation, respiratory depression, all the effects of opioids. Okay. And most of the opioids that we know, like fentanyl, morphine, methadone, all are agonist opioids. What is an antagonist? What is
Just
an
the
antagonist?
opposite effects.
Opposite action. So,
And it causes pain.
okay. So suppose if I give antagonist naloxone, injection naloxone to any of you, what would be the action in your body?
It antagonizes even the respiratory depressant effects of morphine.
Okay. So if I give naloxone to you,
And patient may have more pain.
I'm giving to you injection naloxone, not to the patient. It will not have any action in your body because you are not taking any opioid. Okay.
Yes, sir.
The antagonist acts in presence of an agonist opioid.
Agonist.
Yeah. So if the patient is already taking morphine, methadone, fentanyl, then the antagonist like naloxone can reverse the effect of morphine, methadone, or fentanyl. Okay. So antagonist work only in presence of an agonist. Agonist antagonist means on certain receptors it acts as an agonist, whereas on another receptor it will act as an antagonist. So examples are pentazocine, buprenorphine. And look at this graph. On the x-axis, it is the dose of opioid, and on the y-axis, it is the pain relief. So the first graph is for agonist opioids. So you can see, if you give an agonist opioid, say morphine, if you give 5 milligram, and this patient has the pain score of 10 by 10 until here. And suppose you give 5 milligram of morphine, that will give some pain relief, this much. And if you increase the dose, then it will give corresponding pain relief. So as you increase the dose of an agonist opioid, that will give you more pain relief. So if you give this much agonist, then there will be complete pain relief. Okay, so the graph is a straight line. As the dose of agonist opioid increase, there will be corresponding increase in pain relief. But if you look at agonist and agonist, what happens here? If you increase the dose, then it will give a corresponding pain relief, but that is up to a point. So you can see this point, and beyond this point, even if you increase the dose of agonist and agonist, it will not give any pain relief. The curve plateaus. So there is a ceiling effect.
Ceiling effect.
Yeah. So agonist and agonist opioids have ceiling effect for analgesia, whereas agonist opioids have no ceiling effect for analgesia. So this is another difference between agonist and agonist group. So our pentazocine is a agonist at kappa receptor, whereas it is a weak antagonist at mu. But morphine is a pure mu agonist. Okay, so morphine is pure mu agonist, but pentazocine is weak antagonist at mu. So what happens if you administer pentazocine to a patient who is already on large doses of morphine? So pentazocine can actually displace morphine from the mu receptor. Okay, so pentazocine will displace the morphine from mu receptor. So what is the action of pentazocine on mu receptor? It is a antagonist.
Weak.
It is a weak antagonist. That means the patient can have more pain, isn't it?
Yes, sir.
So for this patient, you will not administer pentazocine. Rather, you have to take a detailed history and find out whether the patient has missed any scheduled dose of morphine. You give it. You can ask the patient to take a SOS dose of morphine. So we here we have another patient, a 70-year-old man with carcinoma of the lung who has neuropathic pain of right upper limb due to nerve infiltration. He is on morphine 10 milligram 4 hourly, amitriptyline 75 milligram HS, and the pregabalin 150 milligram BD. He attends your clinic with the delirium and myoclonus and does not have satisfactory pain relief. How do you manage this patient? So this patient has a neuropathic pain on the right upper limb due to a pancreas tumor which infiltrates the brachial plexus. So this patient is already on a good amount of tricyclic antidepressants and anticonvulsants. So what would you do? Any idea?
We need to reduce the dose of morphine, sir,
Okay, why do you want to reduce the dose of morphine?
because delirium, confusional state also might occur because of the morphine metabolites. And
Yeah, you are right. We have to reduce the dose of morphine. So if you are going to reduce the dose of morphine, the patient will have more pain. And even now the patient doesn't have satisfactory pain. So what would you do? Okay. So here comes the role for methadone. Okay. So methadone is actually a different opioid in that opioid group. Okay. And methadone is available as an isomer of S-methadone and R-methadone. And it acts on all the receptors, opioid receptors, mu, delta, and kappa opioid receptors as an agonist. Whereas morphine is a mu agonist. And it is also an NMD antagonist. That is N-methyl D-aspartate antagonist, which the other in medicine which has a useful NMDA antagonistic action is ketamine. Here, methadone is also an NMDA antagonist, and then it also acts like a tricyclic antidepressant. It inhibits the reuptake of noradrenaline and serotonin. So you can see there are three mechanisms of action which makes methadone a special opioid in the group of opioids. So those are the three useful actions. But you can also see there is another problem. It blocks human either AGO related gene channel in the myocardium, and this can lead on to increase in QT interval, and it can lead to arrhythmias and torsade points and sudden death of the patient. Okay, so this is one of the feared side effects of methadone. I'm not going into details of methadone, but a few important points about methadone is that when you administer methadone for the first time to a patient, it will take about 5 to 7 days for the blood level to be stabilized. Whereas in case of morphine, we told that it will take only 24 hours to stabilize the blood level. But methadone will take about 5 to 7 days. So that means you can increase the dose of morphine every day, every 24 hours. But methadone, the dose can be increased only after 5 to 7 days. And if the patient is elderly and if they have liver failure, then you have to even wait for 10 to 14 days before increasing the dose. And the important point in the pharmacokinetics is methadone is actually excreted from the body mainly through bowel and a little bit through renal route. So it is supposed to be a safe opioid in case of renal failure. And you can see there is a special supplement in which has come in Indian Journal of Palliative Care in 2018 only about methadone. So if any of you are interested, you can go and read this. And there is another article, this safe and appropriate use of methadone in hospice and palliative care, which is an expert consensus white paper in Journal of Pain and Symptom Management in 2019. And this also gives a good account of methadone, how to convert an opioid to methadone. So just read this. What are the indications for starting a patient on methadone? If the patient has opioid toxicity, so this patient already has delirium myoclonic, so this is an indication. Then if the patient has complex neuropathic pain, so our patient who has upper limb neuropathic pain and it is not relieved with the pregabalin and amitriptyline, so this patient has a complex neuropathic pain. And opioid-induced hyperalgesia or opioid-induced tolerance. So some patients can rarely have hyperalgesia due to opioids. And in such cases, or if the patient is on very high dose of opioids, say 100 milligram of morphine every 4 hours, 400 milligram of morphine every 4 hours, in such cases, methadone would be a good choice. Then in patients with a chronic kidney disease, where you have to manage pain, and allergy to other opioids. So some patients might have true allergy to morphine or any other opioids. In such cases, methadone can be used. So these are a few indications in which you have to use methadone. And how do you convert an opioid to methadone? So it is always you have to convert the opioid to morphine, morphine equivalent. So if a patient is on tramadol, you calculate what is the equivalent dose of morphine, and then from there to methadone. So in opioid-naive patients, the dose recommended is 2 to 7.5 milligram of oral methadone per day. And the duration of action of methadone is 8 to 12 hours. So you need to give only twice or thrice a day. And if the patient is taking more than less than 60 milligram, this we already told. And if the patient is taking 60 to 199 milligram of oral morphine, and if the patient is less than 65 years, then the conversion is 10:1. That means if the patient is taking 100 milligram of morphine, you divide it by 10. So that would be 10 milligram of methadone. So you may give it 5 milligram daily. If the patient is taking more than 200 milligram of oral morphine, or if the patient is more than 65 years old, conversion ratio is 20:1. So the same patient who is taking 100 milligram of oral morphine, but he is 70 years old. That means you have to divide 100 by 20. So 5 milligram. A few other things that you need to be aware about methadone is there are a lot of drug interactions. Methadone actually metabolized through cytochrome P enzyme system. So there are a lot of cytochrome enzyme inducers as well as inhibitors. And many of the medications that we use in palliative care have interaction with methadone. So you should be aware about that. And it will take about 5 to 7 days for stabilization. So you have to wait for 5 to 7 days before you increase the dose of methadone. And if you look at the paper and the journal and journal of pain and symptom management, you will understand how to convert. I'm not going into details now. So we have both the morphine tablet as well as morphine syrup available. It is 5 milligram. And now we are moving on to the adverse effects of opioids. Adverse effects we can divide into two. One is side effect and the other is toxic effects. What are side effects? Side effects means these are the adverse effects with therapeutic dosage. So what are the side effects of opioids in general? Anybody?
Constipation,
Yes, constipation.
Nausea, vomiting,
Yeah,
pruritus,
yes. Okay. Most common is constipation, followed by nausea, vomiting, sleepiness, and tiredness. These are the three common side effects, followed by there are few rare side effects: itching, dry mouth, and urinary hesitancy. Okay. And constipation, this occurs almost in all the patients. So once when you prescribe opioid, you should also prescribe a laxative. Not a laxative, you should prescribe a stimulant laxative. So stimulant laxative examples are bisoprolol, sodium pycosulfite, and senna. So any of this should be prescribed when you give opioids to the patient. This is very important. and nausea and vomiting. And another thing about constipation is that you have to continue the laxative as long as the patient is on opioid. In case of nausea and vomiting, it occurs almost in 1/3 of the patients, and that also only for the first few days, maybe 5 to 7 days. Thereafter, a body will be tolerant to it. So, for the first 3 to 5 days or 5 to 7 days, you can give an antiemetic, and it is mainly due to stimulation of chemoreceptor trigger zone. And the most abundant receptors in chemoreceptor trigger zone is dopaminergic type 2 receptors, and the strongest D2 blocker is haloperidol, followed by metoclopramide. So our choice is metoclopramide due to various other reasons. Sleepiness and tiredness, again, this occurs in almost 1/3 of the patients, but this will also this is also self-limiting. Maybe within first 3 to 5 days, the patient will be coming to normal alertness. Toxic effects, that means when you are giving more than the required dose. So what are the toxic effects? Delirium, myoclonus, and drowsiness. These are toxic effects. So if the patient has these symptoms, that indicates that you have to reduce the dose of opioid you are giving. You were talking about opioid respiratory depression. How common is this? Opioids producing respiratory depression.
Very rare, sir.
Very rare. Okay. And so this is a systematic review from 2003. And this says usually patients takes their medication, that is opioid, by oral route. And the dose is only gradually increased, which ensures that respiratory depression is unusual. And they continues to say that if a patient has respiratory compromise, then you should see are there any other risk factors such as a pneumonia, pulmonary embolism, or cardiomyopathy, or are you administering a benzodiazepine along with opioid? Okay, so the chance of respiratory depression, especially when you are giving oral opioid, is very, very low. I have not seen a single patient with respiratory depression for the last 20 years in my career. What about this? Opioids causing addiction.
Yes, sir. They
Okay.
they get addicted.
Yeah. How common it is?
Because as the disease also progresses, the requirement also is more and they keep craving for it.
Okay. Yeah. So I would like to tell you something. These are the research findings. Substance abuse as a result of medical use is low. And there is a confusion between physical dependence and psychological dependence. Their psychological dependence is known as addiction. So a simple example to understand this concept. Many of you would be taking coffee in the morning for the last so many years. And suppose one day morning you do not get coffee because there is no coffee powder and sugar in your home. How would your body manifest? Or would there be any manifestation in your body if you don't take coffee in the morning? Nobody is taking coffee.
Psychological dependence is more.
Psychological dependence. So how do your body react? Headache? Yawning?
Yes, sir. We feel
Irritation?
like
Okay. So that means You are an addict.
If physic. Mm.
Yes. Are you? Okay. But I would say you have physical dependence. If you have psychological dependence, then you will break into the neighbor's house where coffee powder and sugar has kept. If you don't do that, then you have physical dependence. You have been giving coffee for the last so many years to your body. And one day morning you are telling, no, I will not give coffee. Then your body will react. That's physical dependence. But you are not going to the other house and which is locked. You are not breaking into that house. If you do that, you have physical, psychological dependence. So that's the difference between physical dependence and psychological dependence. And we know that many medications can have physical dependence. If you stop atenolol for a patient who is taking long time, what will happen? There will be many problems. Why don't you stop steroids suddenly? So,
Yes.
likewise, opioids, if you give it long time, it can have physical dependence. So you have to actually taper and stop. Okay.
Yes.
And I think now I would show you the comparative prices of opioids. You need to know this. So a patient who is taking morphine 5 milligram every 4 hourly, so totally he would be taking 30 milligram, and the cost would be 3 rupees 50 paise per day. But if you need to give the same pain relief for this patient, you have to give 300 milligram of tramadol, and the cost would be 24 to 50 rupees per day. Fentanyl packs 250 to 400 rupees. Buprenorphine packs 1,220 rupees per hour. And methadone 5 milligram, it is 4 rupees 50 paise. So this is the comparative uh, price of different opioids to give the same pain relief. So you have to think before you prescribe, uh, especially when we have poor patients. They may not be taking this, or they may be taking fentanyl patch or buprenorphine patch only once. Thereafter, they are not going to buy it because they do not have money. So it's our duty to ensure that we would prescribe the medication which is affordable for the patient. So pharmacoeconomics is very important in palliative, not only in palliative care, but in any other specialty. So with this, I think I would stop here. And if you have any doubts, you can ask me. I have not gone details of into details of methadone, but if you see the references that I have given, there is a lot of information from those articles.
Sir, is it available in India, sir? Methadone?
Yes, yes. Methadone is available in India. It's available since 2017 for pain relief. And even before 2007, methadone is available, but that was for opioid dependence or opioid substitution therapy. But from 2017 onwards, we have methadone for pain.
Any other pressing questions which we can take in?
Sir, you mentioned that along with morphine, stimulant purgative should be used regularly, no, sir?
Yes, Dr. Bani.
But again, for a prolonged period, if they are given, won't it cause laxative abuse? And again, it may lead to chronic constipation, leading to decrease in the tonicity of the colon.
So if the patient is taking opioids, that is going to produce constipation. Okay. So as long as the patient is on opioid, we do not have any other way because we have to relieve the constipation. So you should, once you stop opioids, then you can also stop laxatives. So
But you
we
mentioned
will,
they laxate stimulant purgative should be used regularly, sir. How
yeah,
regular?
as long as the patient is on opioid. So many of the patients who has cancer, they will be on opioids for maybe for a few years, I think, and we usually continue to give opioids for those patients, and they do not develop misuse or problems with laxatives.
Can't we instead of stimulant purgatives like bisacodyl, can't we go for another group of laxatives like lactulose or bulk forming purgatives?
Okay. So bulk forming laxatives actually contraindicated in case of opioid-induced constipation. There are many mechanisms by which opioids produces constipation. One is that it increases the ring contractions in the bowel, and it increases the absorption of fluids from the bowel. Then it will increase the tone of the sphincter, and it also reduces the sensitivity to the fecal matter. So we have to give an opioid, an laxative, which will actually work opposite to this opioid-induced constipation by opioids. So that's why stimulant laxatives are it is the choice. Usually it is said it is the choice. But even osmotic laxatives can also be given. But bulk forming laxatives, if you have seen bulk forming laxatives like methyl cellulose, it's like a powder. You have to mix it with water and you have to immediately take it. If you don't take it immediately, what will happen? It will solidify and it will be like a rock. So if you take bulk forming laxative like a methyl cellulose, it will add to constipation. So it is actually contraindicated with opioid-induced constipation. Or if the patient is on opioid, don't give bulk forming laxative. Any other laxatives should be okay, like lubricant laxative or osmotic laxative or stimulant laxative it should be okay. But usually it is said that the drug of choice is stimulant.
Okay, sir. Thank you.
Sir, like how high a dose of morphine can you give?
Yeah, that's a very good question. And I would like to ask you what was the maximum amount of morphine that you have given to a patient?
70 mg PD I had given, sir.
Okay.
Patient of rhinoblastoma was not having any pain relief because the tumor spreading into the skin, and even the eye and even the whole maxillary area now. Not at all having pain relief. Because of the limitation of the drug supply, we had to cut down.
Okay. Yeah. So there is no maximum dose of morphine or opioid for a patient. The dose which is required for pain relief for a patient is the maximum for that patient. I actually had a patient who was an advocate who had a carcinoma of the colon, and I think that we started him on 5 milligram of morphine, but later we had to increase it to 400 milligram every 4 hours. He was taking 400 milligram every 4 hourly. He was going to the court and he was practicing very active. And I know one of my colleagues who treated a patient with osteosarcoma who underwent amputation. He was taking 750 milligram of morphine for hour. But when the methadone is now available, I do not think we need to put this patient on high doses of morphine. They would need only a small dose of methadone.
Okay. Thank you. Thank you.
Priya, I think we can wind up the session.
Yes, sir. So with permission, thank you, sir. Thank you so much for joining us. I know that you might have had a very busy day and your day has not ended, and still you found out time for this batch and enlightened us on management of pain using opioids. Thank you so much. Thank you every participant for making the session interactive, and we do hope such enthusiasm continues till the end of all our sessions. So with a promise that we'll be meeting again tomorrow with another different topic and yet another faculty. This is Sripriya, along with the Dr. Sunil Kumar and Mr. Anup signing off from the Tips Eco. See you in the next session, same time tomorrow. Till then, everyone take care. Bye-bye.
Bye.